Hello, let's rock and roll. Okay. So it is my pleasure to introduce Dr. Pirlamarla. Everyone knows me. So Preethi did her medical school in Drexel in Philadelphia and then stayed on at the legendary Hahnemann University Hospital, which I know very well because I did my training on the East Coast, and then went on to Long Island for her cardiology fellowship at Northwell, followed by advanced heart failure training at the Mount Sinai Hospital in New York. She held positions at Thomas Jefferson and Mount Sinai before joining us earlier this year. And since joining us, we spent a decent amount of time together because we share a 7x10 photo office. Despite that, I realized that I didn't know that much about Preethi, so I asked some friends of hers, and I think the thing that really stood out, sort of like in a salient way, is I would say selflessness and a desire to help people. So just as a story that I think is emblematic, I didn't know this. During the early days of the conflict between Russia and Ukraine, Preethi and some fellow physicians of hers went to the Polish-Ukraine border to help folks out there. And I thought that, I think that just kind of speaks for itself. In addition to that, she's had several roles in equity and healthcare equity, including, for example, a role in a charity, an advisory role in a charity called the Equity in Heart Transplant Project, which is a charity organization that helps people that don't have the funds to get a transplant achieve that. And I think that's just perfectly on theme for you, it sounds like. So she'll talk to us today about disparities in heart failure, and I don't think there's a better person to talk to us about that. So I'm excited about that, Preethi.
Thank you. Thank you, Aris. Can you hear me? Sorry. Thank you, Aris, for that very, very kind introduction. And thank you for having me this morning to speak on this topic. And it's a topic that is especially close to my heart. Prior to me coming here, I actually was director of heart failure for the Queens campus in New York. And that was particularly where my eyes were open to really how disparities can affect heart failure outcomes and heart failure care. And it was something that I found to be very interesting. And so I'd wanted to speak on this topic today. So just to get started. So I have no relevant disclosure. Sorry, I didn't know how to put a new slide, and so it looks like a title slide. So just to kind of go over what I'll be talking about today. So I'll start off with the epidemiology of heart failure, and then I'll start to go into a few definitions, namely about disparities, social determinants of health, et cetera, identify what the etiologies of these disparities are, address how heart failure is impacted by these disparities, and how it can be found in all spectrums of heart failure, from heart failure all the way to cardiogenic shock and advanced heart failure, and then talk about how we can evaluate different areas for change. So just to kind of go over briefly in broad strokes, heart failure epidemiology. So we now know it's the most common diagnosis for hospitalized patients over the age of 65. And currently there's about 6.7 million people living with heart failure, but it's projected to increase to over 8 million by 2030. And there are some thoughts to why we see that. And it's thought to be that there's a earlier diagnosis of heart failure. There's an increase in survival due to improving therapies, people surviving their MIs, et cetera. There's an aging population, and there's also a unfortunate increase in the comorbid factors such as obesity, diabetes, hypertension, et cetera. And we know that it's a giant burden on the healthcare system, and there's a $70 billion projected to be spent in both indirect and direct costs on heart failure. So when we look at the analysis of the multi-ethnic study of atherosclerosis, which is a study of about 7,000 participants within 4 ethnicities that spanned over 4 years, it showed that Black Americans or African Americans or Black participants had the highest incident rate of heart failure. And this was followed by Hispanic patients, then white, and then Chinese patients. And these incidences were driven primarily by increasing risk factors such as hypertension, diabetes, and socioeconomic status. And then when we looked at the difference in hospitalization rates by race, when we look at Black patients, Hispanic, Asians, what we found is that Black men and women, when we look at the years between 2002 to 2013, they had the highest rate of hospitalizations. And what we found is that there really was no significant change and maybe even a little bit of increase in these populations. And this was less than the hospitalization rates for white patients. And then again, if we look at the burden of cardiovascular disease, and this was data from about 2015. So we look at the burden of disease, which is a scoring system that was developed by the American Heart Association, and it looks at 7 different variables. It looks at smoking, physical activity, weight, cardiovascular diet, blood pressure, blood cholesterol, and blood levels. And what it does is it looks at all of these different parameters and how many of these different races may hit. And when we look, what's concerning is that when we look at higher composite scores or higher aggregate, we really don't see that many. But more importantly than that, when we look at this color scale, Black and Mexican Americans actually have a lower amount of clustering of these positive risks, these positive factors. And that really shows that we have a lower presence of factors that are associated with health in these populations. So the question is why? Why are we seeing this? And why are we seeing such a disparity in certain populations when we compare it to others? So that brings us to, let's define what health disparities are. So the National Institute on Minority Health and Health Disparities defines it as a health difference that adversely affects disadvantaged populations in comparison to a reference population based on one or more outcomes. And that could be higher incidence or prevalence of disease, premature or excessive mortality from a specific health condition, a greater global burden of disease, poor health behaviors and clinical outcomes because of that, or worse outcomes on a validated self-reported measure. And we also know that health disparities are closely linked to social, economic, or environmental disadvantages. And when we talk about health disparities, these can affect any number of populations, and that includes racial or ethnic groups, socioeconomic status, sex, gender identity, geographic location, or sexual orientation. And what factors influence heart failure disparities? And if we look at this social ecological framework, it really shows that there's multiple levels of influence that can impact patient behaviors and outcomes. We know undeniably that there are biologic and genetic aspects that affect heart failure outcomes for an individual, but we have to put that in the context of interpersonal, community, and societal factors. So let's start by looking at physiologic reasons for heart failure risk. So we know that there is possibly a difference in the physiology that exists between populations based on genetics, ancestry, et cetera, and that can lead to an increased risk of heart failure. So one example of this is that we know that there's this relative deficiency of natriuretic peptides that are noted in Black, Hispanic, and Chinese American patients. And we know that natriuretic peptides are beneficial in the management of heart failure. And if you have a decrease in them or a deficiency in them, there's an association with multiple adverse phenotypes, and that includes endothelial dysfunction, hypertension, left ventricular hypertension, and the propensity to retain salt or fluid, which is a pillar of management for heart failure. Another example of that is that we know that in certain populations, there's a prevalence of the valine to isoleucine substitution on chromosome 18 at a specific position, and that's carried by about 3.5% of Black people, and that's associated with a higher risk of development of cardiac amyloidosis. An interesting thing to point out is that even though that we are understanding that there may be an ancestral or genetic risk to certain types of heart failure, Hispanic and Black populations are still likely to be less offered genetic testing than other populations. So just to step back a little bit, and when we look at the pathophysiology of heart failure, we know that there is a neurohormonal imbalance. And what we know is that there's different peptides or factors that are associated in the balance of this. So we know that natriuretic peptides, bradykinin, nitric oxide are all supposed to be vasodilating, and they are growth inhibition. And so that improves hemodynamics, prevents remodeling, and really has a declining or beneficial effects on heart failure. And that opposed to vasoconstricting and growth promoting factors such as norepinephrine, because we know that heart failure is essentially a stress-induced condition, angiotensin II, endothelins, vasopressin, et cetera. And all of these are associated with worsening hemodynamics and progressive remodeling. And I bring this up because there are increasing evidence that there is an imbalance in certain populations, and that can impact the development of heart failure. For example, we know that African Americans may have a different phenotype of heart failure. They're more likely to have non-ischemic cardiomyopathy, and that usually is driven more by hypertension, which is something that we see develop and may be associated with this pathway. And what's more important to note is that certain therapies that are considered staples or pillars of heart failure management, such as ACEs, ARBs, RNAs, we know that they are less effective in certain populations, such as African Americans, than they are in other populations afflicted by heart failure. So looking at some of the molecular physiology or the biology behind the development of heart failure, we know that nitric oxide is critical for the homeostasis of our vascular system. So when we have nitric oxide available, we have circulating guanylyl cyclase that leads to the upregulation of cyclic GMP. Cyclic GMP is important because it binds to protein kinase and creates a complex, which downstream causes a counter-regulatory influence where it downregulates calcineurin, and that impedes the development of ventricular hypertrophy. The most important part of this is that nitric oxide causes a retardation of ventricular hypertrophy. However, when we have cofactors that are needed for the development of nitric oxide, when these are depleted, we have these other oxides that are formed, such as peroxynitrate, which actually upregulates apoptosis. So when you lose this signal, you reduce hypertrophy and you gain a signal to introduce programmed cell death. And so why do I bring this up? Because it is hypothesized that this pathway is out of sync in certain populations, namely African Americans. And we see this in our clinical trials. And one very important trial that really kind of demonstrated this was the VHAF trial, which was one of the very first randomized control trials of its size in heart failure. So as you may know, VHAF was published in 1986, and that was when it predated the use of ACE inhibitors and beta blockers in heart failure. And it was a trial that was designed to show where 640 patients with chronic compensated systolic heart failure were randomized to isosorbide and hydralazine, prazosin, or placebo. And what was found in this trial was that there was a trend towards survival in patients with isosorbide dinitrate and hydralazine compared to placebo. And the main takeaway from this was that the post-hoc analysis suggested an improved survival with these medications among self-reported Black patients. And really what this did was then make room for further trials downstream, such as VHAF2 and AHAF, that further prove this point. So when we look at outside of this, when we look at traditional cardiovascular risk factors, we know that much of the increased burden of heart failure in patients that are Black or Hispanic are driven by a higher prevalence of our traditional cardiovascular risk factors. As we were just speaking about, hypertension is the strongest risk factor for incident heart failure in Black patients. But other factors include obesity, diabetes, and physical inactivity. And we know in Hispanic populations, the process of acculturization or assimilation into American culture has been associated with a higher prevalence of obesity, sedentary lifestyle, hypertension, and diabetes. But there's more to this than just physiology. So we now know is that social determinants of health, structural racism, and neighborhood environment also contribute to the development of not only cardiovascular risk factors, but also heart failure. And this limits opportunities for healthy lifestyle behaviors for individuals from low socioeconomic status and minority subgroups. And one trial or study that really demonstrated this was the Jackson Heart Study. So the Jackson Heart Study is a single-site community-based epidemiologic investigation that really looks at environmental and genetic factors that are associated with cardiovascular disease amongst African Americans, and it's funded by the National Institute of Minority Health and Health Disparities, and it spanned almost 20 years, and it had started in the 1990s. And one of the things that they found, for example, is that participants with more stress from a lifetime of racial discrimination were more likely to engage in unhealthy behaviors, such as tobacco and alcohol use, poor diet, physical activity. But adjustment for those behaviors attenuated the incident hypertension. So when we talk about social determinants of health, what we're talking about is the conditions in the environment where people are born, live, learn, work, play, worship, and age, and that affects a variety of health, function, and quality of life outcomes and risks. And it's defined by 5 different categories, which include education, access, and quality, health care and quality, neighborhood and built environment, social and community contacts, and economic stability. And these are very all-encompassing. So when we talk about neighborhood and physical environment, that includes housing, transportation, playgrounds, access to grocery stores, the geography of the area. Education includes literature, language, early childhood education, higher education. When we talk about food, we talk about food security. Do we have access to healthy options, access to grocery stores that carry particular food types? And then when we talk about community, we're talking about the inherent support systems in the community, engagement of the community with each other, et cetera, and exposure to violence and trauma. So any of these are drivers for social or economic inequities. And what we know is that with that on top of racism or discrimination, this can have a high impact on mortality, morbidity, life expectancy, healthcare expenditures, et cetera. And we also have to kind of address structural racism. So what is that exactly? So it's defined as racial discrimination that is fostered by laws and practices sanctioned and implemented by various levels of government and embedded in the economic system as well as in cultural and societal norms. So really it's multifactorial and comes from multiple different facets of society. And what we know is that it disproportionately limits opportunities for social, economic, and financial investment for certain race and ethnic minorities. And this in turn can result in negative health outcomes. For example, income inequality. We know that workers of color are more likely to be paid lower wages than white workers, and that can affect access to certain benefits, such as insurance or access to medical care or medications. Violence and mass incarcerations. Time and time again, there have been studies that demonstrated that stress content of an environment play a role in the social determinants of health. And there's a link between increased neighborhood violence and chronic disease. And we know that there's a higher prevalence of diabetes, hypertension, obesity, and early mortality. Neighborhood environment and residential segregation. Black and Hispanic neighborhoods, Black and Hispanic patients more likely live in impoverished neighborhoods due to historic things such as redlining or exclusionary zoning. And those living in racially segregated neighborhoods are more likely to develop our traditional cardiovascular risk factors such as hypertension, diabetes, or obesity. And lastly, provider or health challenges. We know that certain lower socioeconomic areas or groups tend to have lower health literacy. We also know that certain populations, such as Black and Hispanic patients, are more likely to obtain their care from emergency departments rather than ambulatory clinics. They're more likely to lack health insurance. And also, unfortunately, they're less likely to be referred to specialists for care or to get specialty care for advanced conditions. So how are these disparities driving outcomes? So we already talked about how there's a higher incidence of heart failure in these patients. And hospitalizations overall have increased from 1.06 million to 1.27 million in the past 5 years. What we also have found is that there's an increased proportion of Black patients and Hispanic patients that make up these hospitalizations. And then patients in the bottom 1/4 of household income are accounted for 33% of hospitalizations. And we also know that Black patients account for over half of hospitalizations for heart failure in adults less than 50 years old. And we see these disparities in device therapy and advanced therapies also, such as ICDs and CRTs. So women and racial and ethnic minorities are less likely to receive ICD counseling. And then when we looked at the Get With It Guidelines registry that spanned from 2011 to 2014, even those who were counseled, and that was about 4,500 to 4,600 patients, Black and Hispanic patients were still less likely to receive ICDs. When we look at heart failure mortality by race and sex, we found that there are higher rates in Black men and Black women compared to white men and white women. Overall, heart failure mortality decreased from 1999 to 2012. However, it increased again from 2012 to 2017. And what we also found was that there was disparities that just increased over time. For example, in 2017, Black men had a 1.47-fold increase, a higher mortality rate compared to white men, and that was up from 1.16-fold in 1999. And this was also seen in Black women. What's also more concerning is that you see that there's more of a separation in the recent years, specifically in the younger population. And we also see that there's a disparity in rural regions, and that's something I'm especially learning now that I'm practicing here in the Pacific Northwest. So there was a retrospective cross-sectional study of Medicare fee-for-service beneficiaries age 65 and above. And this study looked at acute cardiovascular conditions, including acute MI, heart failure, or ischemic stroke from the years 2016 to 2018. And this was adjusted for age, sex, poverty, and clinical comorbidities. And what we found was even adjusting for those, there was an increase in mortality in both 30 and 90-day mortality in rural settings when we compare this to urban settings. So disparities not only includes race and ethnicity, but we also are talking about geographic locations and how that can impact outcomes for these patients. So when we look at disparities in the management of critical ill patients, so moving on kind of to the next spectrum of heart failure. So this was a study that was published by Dr. Breathitt that retrospectively evaluated patients that were admitted with heart failure to ICU care. So through a data analysis of the Premier database, patients over the age of 18 years were admitted for heart failure diagnosis to an ICU were evaluated. And what they looked at was to see if these patients were managed by a cardiologist or a non-cardiologist. And this study demonstrated that African Americans were less likely to receive primary ICU care by a cardiologist. And that's important because what it found was care by a cardiologist was associated with a higher in-hospital survival in both Black and white patients. Another study looked at patients with ST elevation MI and cardiogenic shock. And this study looked at racial and gender differences. And what they found was that in women and Black patients, they had a higher in-house mortality, and they also were less likely to receive an intervention such as revascularization, MCS, or a right heart cath. So kind of moving through the spectrum of heart failure, we looked at chronic heart failure and the disparities there, critically ill patients. But do we see this in advanced therapies? So overall, when we look at the numbers for cardiac transplant, we know there's a constant imbalance. The data from 2019 showed that there was a wait list of about 7,386 people that were waiting for a transplant, and about 3,700 patients were transplanted. So already we have a deficit where we have patients that were waiting and not enough hearts to go around. And every year there's at least 4,000 new patients that are waiting for a transplant. So it's a constant imbalance, and it almost kind of feels like you're Sisyphus, where you're trying to move this rock up this uphill, and it's always an uphill battle, and you're really never getting ahead. And it's because of so many different factors, psychosocial factors, economic factors, but we know that the path to getting a transplant is an arduous one. So when we look at disparities in access to advanced therapies, very similarly to chronic heart failure, there's multiple areas where disparities can impact getting access to a transplant. Insurance, referral patterns. We've already seen that patients from certain groups are less likely to be referred to a cardiologist or for advanced care. Comorbidities. We already know that certain populations have a higher incidence of hypertension, obesity, diabetes, renal disease, social support and education, patient-centered decisions. We already know that certain populations may have a lower health literacy, adherence, and that is impacted by many things, mainly insurance, health literacy, et cetera. And certain implicit bias also can take account as well. So if when we look at insurance and access, does that affect access to transplant? So in this retrospective analysis of heart transplant and LVAD evaluations from 2012 to 2016, they evaluated association of insurance type with treatment eligibility and 1-year survival. And what they found, and so this was a study from Georgia, and it looked at Medicare and Medicaid data. So Medicaid data showed that patients were generally younger, generally Black, fewer comorbidities, but they found that Medicare and Medicaid predicted lower odds of eligibility for transplant. Medicaid patients were less likely to receive a DT-VAD, and there was an increased risk of death. And we also found that Medicaid insurance was a predictor of lower survival among patients that were not listed for transplant despite fewer medical comorbidities. So another study, interestingly, looked at public and private insurance, and it looked at people with continuous private insurance, transition to private, continuous public insurance, transition, and it looked at that if there was any connection with that with survival after transplant. And then in this study that they found was that even after you adjusted for certain factors, including education, donor and recipient factors, etiology of heart failure, et cetera, mortality after transplant is better if you have private insurance compared to public, or if you had public with transition to private. And it was important to show that even when you adjusted for those, mortality was still better for those with private insurance. So the question becomes is why? Why is it that those with private insurance seem to be doing better? And there was a really great editorial that came after this paper that took a look at that. And one of the things that it pointed out is that public health insurance, when you're looking at the data for it, it's likely a surrogate and it's capturing for other complex factors that we may not be able to account for otherwise. And what we also know is that public health insurance can sometimes be a potentially inferior choice for certain patients for many reasons. One, lower reimbursement rates, restrictions on medications covered under public insurance plans, higher copays, difficulty to get certain medications such as immunosuppression medications, and it may actually reduce access to specialized physicians or primary care physicians. And that can in turn lead to increased medication non-adherence to medical visits, or other inadequately addressed comorbidities. So when we look at the SRTR data, which is the National Registry looking at transplant recipients, and it collects data from all solid organ transplants. When we look at the 2022 data, you can see when we look at the transplant rates have increased in all groups. However, the ones that have shown the least growth was those that included the Hispanic and Black populations. And when we looked at disparities in the likelihood of transplant, in a study in 2021 in the Journal for the American Heart Association that looked at racial and ethnic disparities in cardiac transplant, this study looked at adult heart transplant recipients from 2011 to 2010, and they stratified it into 3 groups: Black, Hispanic, and white. And when we looked at outcomes out of these patients, and they looked at a group of 32,000 patients, Black and Hispanic patients tended to be younger, more likely to be women, more likely to have diabetes or renal disease, and they were less likely to undergo transplant and also had a significant higher risk of post-transplant death. So what about LVADs? So this study looked at patients getting LVADs as a bridge to transplant. And in this trial, patients were stratified by race. And when you look at waitlist outcomes and death, Black patients were more likely to die awaiting for transplant and less likely to receive transplant. And this disparity translated into an increased waitlist morbidity and poorer outcomes. And another study looked at gender disparities in VAD to bridge to transplant outcomes. And in this study, which was a UNOS analysis of continuous flow LVAD recipients, women were less likely to be transplanted. The waitlist mortality was higher, about 50% higher than in men, and more likely to be delisted for worsening clinical outcomes. And all of these were statistically significant. So aside from the socioeconomic factors that are a challenge to transplant, we also have to take into account there are physiologic challenges to equity in transplant also. For example, sensitization, and this is something that comes up very often in transplant. So sensitization is essentially when we are talking about the number of circulating antibodies that a patient may have. And that's important because it limits the ability for a patient to get transplanted as it increases the likelihood of post-transplant rejection. And so basically what is done is what we look at a recipient's blood, and we'll look at for the number of antibodies that they may already have that are preformed. So about 30% of candidates tend to have some degree of sensitization, and it can be caused by a number of allosensitizing events, such as pregnancy for women, blood transfusions, et cetera. And the reason we talk about this is that it can impact what's a suitable donor match. And it also can increase wait times for patients as we're waiting for those that may have an appropriate match based on their sensitization. We know that this disproportionately affects women. We also know that Black patients have a higher PRA, or panel of reactive antibodies. They're more likely to be sensitized, and they also might have a greater degree of mismatch. The problem with this is that therapies for this, such as desensitization, are typically costly, and they may not always be covered, which is a problem for patients that have lower coverage of insurance. And there's a lack of standardization on how to manage this. And so it's yet another way that transplant care is impacted. So what can we do? So in 2022, when the Joint Management for Heart Failure guidelines were put out by the AHA, ACC, HFSA, disparities were actually brought forward as something that needs to be addressed. There are important differences in heart failure incidence, risk factors, clinical needs, et cetera. And it's essential that heart failure clinicians be aware of the biologic factors, social determinants of health, and implicit biases that may impact decision-making or the delivery of care. And it also noted that important strategies to remove these is essential for adequate heart failure care. There's multiple targets for reducing heart failure disparities, and these are just very few broad things that have come up on how do we reduce these disparities. For example, in healthcare and healthcare systems, increased use of telehealth, because it has been shown that certain ethnic groups are more likely to use telehealth over inpatient visits. Ensuring follow-up, heart failure hospitalizations and follow after is a competency for the management of heart failure. So ensuring adequate heart failure follow-up to prevent readmissions is an important target for improving disparities. Increasing patient education programs to improve health literacy, and increasing representation of minority populations in clinical trials, because as we know, historically, they have been underrepresented. Health policy is another major target, such as the expansion of the Affordable Act or the Inflation Reduction Act that was passed in 2022 that is thought to maybe help estimate or is estimated to lower patient medical costs. There are multiple areas that we can target for reducing heart failure disparities, and that comes from different areas: structural policies, health systems, community, interpersonal, and just individual as ourselves, where we find that we can reduce heart failure disparities. So take-home points. Healthcare disparities in heart failure are multifactorial, and they're a complex interplay of both physiologic, genetic, and social determinants of health factors. Those that are the highest at risk are Black and Hispanic patients, those in rural regions, women, and those of low socioeconomic status. And what we know is that we see it across the spectrum of heart failure, from chronic heart failure all the way out into advanced heart failure. And addressing these requires an intervention on multiple levels of society, from government all the way down to individual intervention. I'd like to stop there and see if there's any questions, and thank you so much for having me. Thank you.
That was great. April, are you raising your hand or are you stretching? Okay. I'll start with any questions around the room. April.
It was a great talk, Preethi.
Thank you.
I had a question about the interaction between stress and physiology. So did you come across anything about sympathetic nervous system activation in response to racial stress or socioeconomic of disease stress?
Yeah, there was, I didn't have a chance to put it in, but they found that in certain neighborhoods, uh, exposure to violence, exposure to either whether it's gang violence, police violence, et cetera, they found that they had higher like post-traumatic stress disorder, higher rates of on self-scoring of rates of stress. And they also found that they had, when they did surveys, they had lower sense of security and lower sense of feeling of safety. And in those populations, they found that they had worsening outcomes and higher prevalence of cardiovascular risk factors. I didn't see anything about whether or not they actually, tracked biologic markers, but they did find that they were associated positively.
Preethi, I have a question. So, you've been doing this for a while now. So, it sounds like there's kind of two ways to address this. There's like a way we control, as in like the scientific community and physicians and all the things we spoke about with outreach and sort of like diversifying populations in clinical trials, barbershop interventions, all that stuff. And then there's sort of blue chip policy interventions that can be sort of like, in my mind, a little bit impractical to achieve and difficult to move the needle and so on and so forth. So it's a little bit of a fluffy question, but like in your experience, what do you think is going to be more effective in like helping with this problem? Is it going to be us or is it going to be like politicians?
It's a great question. I think it's multi-level, truly. From our standpoint, I think that in the heart failure world, there's been a tremendous stride in identifying that there's disparities and that they need to be addressed. And we've seen this explosion of, data and research that's come out and looking at, geographic differences, racial differences, et cetera, and an increased effort to, involve certain, multiple ethnicities in clinical trials. So I think from a healthcare standpoint, I think at least from the heart failure side, there's a tremendous move. From healthcare policy side, I think maybe there is movement, like we were talking about. The Affordable Care Act has come in. I put it in the slide here, but the new acts that are looking to reduce costs for medications. But so I think it truly is multifactorial. But to speak on like heart failure or healthcare, I think we are making a tremendous stride in awareness for that. I don't know if that answers your question. So.
April?
Well, I would just like to point in that we here are making strides in that with developing this heart after liver transplant program, because that addresses the issues of Should I do it or not? Oh, that one's better. Throw that one away. So the heart after liver transplant for patients with high PRAs as a way of treating that. So all of the patients that we've utilized that in have been women, and half of them have been minority women. So I think that's something that we ourselves as a program from a scientific and clinical implementation have tried to, we just published on it to try and show other people that this can be done.
Yeah, and it's a tremendous effort, and I think it really is a great path forward. There are a few I see on Zoom. Okay. Is it okay if I? Okay. I see that Dr. O'Brien and Joanna Lynn Shepherd also. Okay, we'll have you next. Thank
Hello,
you.
thank you for your presentation again. I had one question, which was about regarding medications. So I heard that especially with development of pharmaceutical and medication, that the development process usually opens the potential for different amounts of effectiveness in different patients, whether it's like gender or like racial situation or background. So I was wondering, has there been any research about this in a cardiology setting?
Yeah, it's a good question. I think what you're kind of alluding to is like precision medicine, which is definitely something that is evolving about medications that are tailored to the patient and based on their, either genetic background, et cetera. I think there is some work that still is being done in that direction. Like we spoke about earlier, we already know from prior studies that there are certain medications that are less effective or more effective in patients, such as isodil in hydralazine compared to ACEs, ARBs, ARNIs. Has there been new identifications for drugs that are on the horizon? Not that I personally know of, but I know it's definitely something that has gained a lot of attention and interest.
Thanks. I think that in many ways answers Dr. Linker's question. There's a really interesting question about Jim Kirkpatrick. He asks, many studies conclusively demonstrate disparities, and demonstrating this was really important. But now do you think perhaps these studies are making us numb to it? Paradoxically, are they convincing us that this is just the way things are and inducing a sense of therapeutic nihilism about it?
It's a great question. I think that personally, it's probably always good to have that something that is addressed. The first real studies or trials that looked at it came from the late 90s, early 2000s, and we saw that there was really more of an explosion, essentially because of COVID. During the pandemic, which it really came to focus. And since then we've seen a growth, but I think it's never too much. As each trial comes out, we're seeing different facets that are affected by disparities, and different areas for improvement. And like April just pointed out, like newer therapies we're finding or newer interventions we're finding are addressing them. So I think it's always something important to keep in the back of our head or on the forefront or however we want to see it. That's a great question.
Melish Thompson is asking, are there any countries with diverse populations that have eliminated or improved upon disparities and that have better global heart failure outcomes than the United States, to your knowledge?
Oh, that's a great question. So the question was, are there any other countries that might be doing
better job?
Yeah, that's a great question. Yeah, I'm not sure. I to be fair, I don't know how much it is actually looked at from a global perspective. But that's a great question and something for sure to look into for a future topic.
And then there's one question from Kevin. Multiple social determinants of health are embedded into the selection process for VAD and transplant, such as requirements for caregiver support, medical literacy, stable housing, et cetera, and can adversely affect a patient's candidacy for those. Because we know that these factors affect patient outcomes, how do you think we can better address it specifically in the advanced therapy selection process?
That's a really, really good question. And I was trying to find the time to put that in the presentation, but I didn't think I was going to be able to fit it in, but it's a great question. And that's come up in multiple talks as well. And some of the ways that there's been a thought to address that is, when we do our social evaluation is, using different scoring techniques that are a little bit more objective when we look at things like our social determinants of health as a way to be a little bit more objective in our process, our selection process. And there are ongoing trials that are going around that actually look at the selection process and to see if there's implicit biases. I know that Dr. Breathitt's doing one that's a multi-site trial that's looking at that. But yeah, one of the ways is to see if there's a way to have more objectivity in some of the social evaluation as a way to potentially prevent some of the disparities that we're seeing. Kevin, I hope that answered your question.
Really interesting talk. And I think you brought up this point of the things that can happen within the healthcare system and the things that can happen outside that we have less control over. RS flagged this as well. And I wanted to bring up the example of the community heart failure program that's been developed at Harborview here to explicitly address the disparities around heart failure patients who have substance use issues. And the choice that our health system made to invest resources to work outside of the traditional sort of playing field that we have access to as physicians. And so you're raising like a whole range of other disparities that are beyond, what we normally can get at as physicians in practice at a hospital or at a clinic. I mean, do you think our health system should invest resources, or other health systems should invest resources to do more work in the community to address these kinds of disparities? And because that's a softball question, if you do, why haven't they?
That's both great questions. To your first one, yes, I definitely think that as a healthcare system or system should be involved more with their community. And actually, one of the papers that I was looking at was actually suggesting certain ways to do that, which is partner with local supermarkets, et cetera, to have incentives if they allow for purchasing of certain groceries that not all patients may have access to, and other kind of programs that could potentially close some of these disparities. So yes, I think absolutely there's a role, and we should try to. Why do I think they haven't? Namely, I think logistics, I think it's sometimes very difficult. For example, that example of partnering with local groceries, I think, how do you do that? How do you get access to the patients to get to the grocery store? Just simple things like that. I think it's a huge undertaking that should be done. But I think when we actually go into the granular details of how to do it, I think that's where we kind of hit a snag. And that's part of the reason I think we haven't been able to just yet. But I think that's a great point to bring up, and we should definitely be doing it more.
Just as a segue to that, Kate Smith is also mentioning that, there's a technology divide with patients that come from different socioeconomic backgrounds, as well as a lot of medical trauma that people go through admission after admission. Any other questions from the in-person team?
And I think,
Dimitri?
yeah, we think we have 2 or 3 on Zoom also, but yes.
Like, we have data, like we see the disparities for sure, right? But we worked day by day, like in the hospital. A few times we don't discharge people on medications, or we take decisions based on things, right? But based on different scenarios we encounter, right? Do we have like a data that says like what drove those decisions of like the patients not receiving like a VAD, or why are we having this disparity?
And I think it comes down, it's a great question. I think it comes down to just so many different variables that could have come in play, like Dr. O'Brien said on the meetings, caregiver, higher comorbid conditions, things like obesity, diabetes, et cetera. It's no one thing, that's likely impacting, insurance access, do they have, insurance? Do they have the ability to pay for the medications if they have high co-pays? Is there a prohibitive, comorbid condition that they weren't able to get treated, is there some physiologic reason that they cannot get an LVAD? So I think it's so many different levels that could be impacting why they're not able to get transplanted or LVAD.
Like those same is it because of social issues? Is it because of the disease process, or have there been?
Yeah, there's certain, I think studies that have looked at that a little bit more granularly that I wasn't really, it's such a broad topic, I wasn't able to get it all in, but yeah, there has been, and hopefully if I'm able to do a follow-up talk, I'm happy to go through all of those too. Thank you. I think we have a few on Zoom.
Well, we have some raised hands.
Yeah,
We have,
yeah.
for example, Jeff Propsfield, I imagine. We're gonna allow you to talk. If you want to unmute yourself and ask a question, Jeff.
It's a mistake. I'm sorry.
All right. And then Kevin, another question from you, or the one you asked in the chat?
Yes, I do have a question, another question, or an observation. So UW Medicine's also working on getting CMS approval to operate something called a hospital at home program. It's a great program for people who are lower risk patients who otherwise would require heart failure hospitalization. And I think it's a great opportunity to be able to assess factors in the home environment that could affect rehospitalization and that are otherwise invisible to us. So, and in many ways, I think it's complementary to these patients have to have stable housing. So it's the Harborview Community Heart Failure Program and this are actually complementary and not overlapping. So that's just a comment.
Yeah, no, thank you. We had a similar program in Queens, like a heart failure at home, and to exactly what you were saying, it was a great bridge, provided the patient had a stable housing. It was a great way to reduce heart failure readmissions because you're able to deliver heart failure care immediately. The one burden we had was we had so many patients and just not enough staff to get to everyone what we needed, but it really was a great program to your point.
Monica, did you have a question? Do you want to unmute and ask it, or? Okay. And then there's one more comment from Maria Teodori up at Northwest, who's a heart failure nurse. Plug for the Edmonds Food Bank. They're looking at starting a prescription for food, quote unquote, working with healthcare providers to ensure people with health issues find the right foods recommended by their healthcare providers. Cool.
That's great. That's great. If you could provide more information about the chat in the chat, that would be fantastic. Thank you.
Dave Ellison.
Well, that's a very interesting presentation, Preethi. Nicely
Thank
done.
you.
I wonder sometimes the scope of this problem is so large, and there are so many features that as medical providers we can't necessarily control. And I wonder if there's a definition-based problem where disparities you defined as comparator to a reference population. And if we constantly compare to the highest educational quartiles, the wealthiest quartiles, if disparities are, I don't want to say exaggerated, but sort of different and more challenging to understand. And if you can compare within a population to patients who have done medically well versus medically poorly, you can more tailor interventions to things we have more control over. And I'm wondering if there's been any sort of look at those things at a more granular level.
Not to my knowledge, but you make a great point, and you know, kind of to your point, if we look at trends, which I think some studies are looking, you know, for example, the first or the second slide that I had, where it was looking just within the population, let's say Black American, like Black men, from 2012 to now, and there still isn't a reduction. Compared to like 10 years ago. But like to your point, that might be one of the better ways to target goals if we look at trends over time versus against other populations. But I haven't seen any studies that have done what you were saying, which is a very good point. Any other questions? I see Kevin, you have your hand raised. Is from the prior question or a new question?
Oh, well, I'm sorry, I forgot to lower it. But you know, I think it's sort of what's that Chinese proverb, journey of 1,000 miles starts with a single step. You know, we need to just be intentional about trying to start programs that can help to improve this problem, and you know, not expect that it's gonna be completely solved right away.
Yeah, and I totally agree with you. Thank you. All right. Thank you. Thank you very much.